So welcome. I'm really glad to see you all here. It's a great opportunity for me to share publicly, I guess, my partner at work, who is just an amazing nurse and young enough to keep up with me. So that's just wonderful. So anyway, welcome, Taryn.
Hi, everyone. Hi. So the date was not done on purpose. This is a recycling of a presentation that I first made in 2012 to give to the nurses and nursing assistants in skilled nursing and assisted living. So every time I'm asked to give this presentation, I review what I prepared back then, and I missed a sort of important part. Also, I usually try not to talk too much about myself personally when I'm at work, but I wanted to apologize for sitting in sort of a strange place during this presentation. I understand most of you can't see me. I have a health condition that flares up every once in a while, and it makes it very difficult for me to stand for long periods of time, so I hope you understand that that is why I'm here. All right, thank you. Everyone's nodding like they sort of get it, so thanks. So today we're going to talk about dementia, which is one of my favorite topics and passions, and I hope that you enjoy the presentation. So what is dementia? I think that the most important distinction that I can make for you is that dementia is more than one thing. It is a number of syndromes and diseases that cause cell death in the brain, and therefore a number of different brain-related symptoms. It's also important to understand that dementia is not a normal part of aging, even though it affects significant numbers of older adults. Memory loss, to a certain extent, however, is a normal part of aging. So it's normal, you can breathe easier now. So it's normal to sometimes misplace your keys. And it's normal to walk into the kitchen, get there and think, why am I here? What did I come for? It's especially normal if you ultimately find your keys and you ultimately remember, you want louder? Okay.
No, it was a light thing.
Oh, lights, okay. So it's particularly normal if you ultimately find your keys, or if you spend a moment looking around the kitchen and finally your eyes fix on the coffee machine and you realize, aha, that's why I came here. Those are normal symptoms of aging. Occasionally not remembering someone's name that you see in the hall every once in a while. This is all normal. What we're going to talk about through the course of this presentation are a number of symptoms that are more severe and that are suggestive of disease rather than normal brain changes occurring with age. There are a number of different areas of cognition that are affected with dementias, from memory to spatial reasoning to language skills, personality, and we will discuss all of those. And in its later stages, dementia makes living alone and independently very, very difficult. And most people with dementia, particularly progressive dementia, will ultimately require some advanced assistance in order to achieve their activities of daily living, like the basics, getting up, getting dressed, getting showered, eating, those sorts of things, ultimately will require assistance in a person with dementia that's progressive. So, as I've alluded to, dementia is an umbrella term. It's not one disease. So, the diagnosis of dementia alone really isn't specific enough to let any, a clinician or a person know exactly what's wrong with someone. Dementia includes a number of different types of diseases. The most common is Alzheimer's disease. Alzheimer's disease of all of the dementias is going to affect by far a significantly greater number of people. Although to a certain extent, I think that this is just my own personal opinion, I think that as medicine continues to advance, we're going to become more adept at recognizing other forms of dementia, and I think we're going to see higher numbers of diagnoses of vascular dementia, personally. But all right, so Alzheimer's disease is the most common. We are going to talk for essentially the duration of this presentation about Alzheimer's disease specifically, because it receives far and away the most funding and therefore research, and we know a lot about it. Other dementias include vascular dementia, mixed dementia, which might be a combination of several different types of disease processes, frontotemporal dementia, which is also known as Pick's disease, Lewy body dementia, which is related to Parkinson's disease. There are other dementias that are less specific to the older adult population, like HIV-related dementia and Creutzfeldt-Jakob dementia. And there are also syndromes, clinical syndromes that appear like dementia but can be reversible. So there are times when people show symptoms that may be similar to those that are exhibited by a person with dementia, but maybe they have an underlying infection or another cause for those symptoms. So as I mentioned, the majority of this presentation will focus on Alzheimer's. We'll hit a couple of the big ones briefly at the end. Here we go, Alzheimer's. All right, so I am a little bit of a science nerd at heart, and my favorite thing to do when educating people about dementia is to guide them through a tour of the brain. And if any of you are physicians or scientists, you might find that my accuracy isn't 100% spot on, but I think it's like 99% spot on. And the goal is people with dementia, we'll talk about Alzheimer's at this point. Alzheimer's affects oftentimes lots of portions of the brain, and different parts of the brain are responsible for different abilities. And I think it's really helpful to understand what those are, so that then when we are interacting with a person with dementia, it's a little bit easier to understand their behaviors and their deficits, because we know how a healthy brain works. So I'm going to take you on a tour of all the highlights, and it's going to be fun. All right, so I love this image. I've loved it ever since the day that I found it, and I don't think that it's ever really left my mind because it's so powerful, I believe. This is obviously two human brains. The image on the left is the brain of a person with advanced Alzheimer's disease, and the image on the right is a brain of a person who we could consider normal or healthy, a control subject. And I think it's pretty obvious the difference. The difference is that the brain on the left has visible tissue loss. Cells in the brain have died, and it has resulted in actual shrinkage of the tissue. And if you imagine that, every square millionth of a millimeter of your brain is responsible for something, and you realize how much of it in this photo has gone, I think it's a little bit easier to understand the fact that people with dementia are struggling with a number of deficits, and things become much harder because they literally have lost the tissue that's responsible for allowing them to carry out certain functions. Alzheimer's disease is clinically diagnosed on the basis of symptoms and progression. So you can go to a doctor and present a certain way, and the doctor may give a diagnosis of Alzheimer's disease. However, it can really only be diagnosed definitively in post-mortem or after-death autopsy and dissection of the brain. And these two big words, amyloid plaques and neurofibrillary tangles, are the specific things in the brain that differentiate Alzheimer's disease from other types of dementias. And so it's more complicated than is necessary, but oh, you guys, I forgot, I have a little light. Okay. This is going to make it so much easier. All right, so this is a very small picture, and you can't really see it, but it's this image except with the cells looking healthy. And I'll point out the main difference. So this is obviously, not present in the other picture. This is representative of amyloid plaques. It's basically junk that is in the brain A normal, healthy person is able to rid this from their brain, but a person with Alzheimer's disease is not. In fact, new medications are looking at different ways of how we can program endosomes, which are special little things within the cell, to pick these up and take them away better, right? So that they don't get in there and clog up the brains of people with Alzheimer's disease. But, so these are amyloid plaques. They're not supposed to be there. And this here, compared to this cell down here, this is a cell with neurofibrillary tangles. Basically, this is a nerve cell. These are the little synapses that sort of join it to an adjacent nerve cell, and it allows them to talk to each other. And that's how our brain works, is sending messages from one to the other. Well, in a person with Alzheimer's disease with neurofibrillary tangles, these nerve cells begin to sort of crinkle and shrivel in such a way that the cell is no longer able to function the way that it would ideally. It's sort of like a back road that becomes blocked because of a fallen tree, except that that fallen tree is never cleared and happens consistently and repeatedly throughout the brain, slowly causing, inability of those cells to function. All right, off on the tour. So we're going to start with the frontal lobe. The frontal lobe, conveniently, is in the front of your head. It is behind your forehead. This is a really important part of your brain. It's the part of your brain that allows you to be you. It allows you to make decisions, to feel motivation, to make plans. It is a filter. And so the way that I think about it is, if I put my hand over my forehead and my hand is nice and tight and it's closed, this is a good solid frontal lobe with a good filter. In people with Alzheimer's disease and other types of dementia, but Alzheimer's disease in particular, the frontal lobe tends to be hit pretty hard, at least in the middle stages. I sort of start to think of the frontal lobe as more of a sieve, right? So if I spread my fingers and then put them on my forehead, my filter is no longer quite as effective. And so what you'll see symptomatically is that when the frontal lobe is damaged, individuals have difficulty with impulse control, regulating their emotions, with inhibition. So a person with dementia, I'm sure you've had the experience of someone maybe saying something that they otherwise wouldn't have said, right? You begin to have symptoms of dementia and you use a word that you never ever would have said before, or maybe someone frustrates you and they say, "I hate you," instead of being calm and collected like you would have been when your filter worked really well. So that's the best sort of analogy for the frontal lobe. The parietal lobes. You've got two parietal lobes. They are right here. Y'all can't see me. They're right here and right here. So the top of your head on both sides. This is my favorite slide of all. There's something about these pictures that I really love. The visual image, I think, makes it really easy to understand. So the parietal lobes are responsible for order, structure, sequence, and spatial navigation. And I've never really known if this image, this red image up top, is actually, real, if it was elicited from a person with dementia, or if it's just an image that helps to demonstrate the point. But I like to think of it as though a person went in to see their doctor and the doctor said, "All right, Mrs. Smith, draw me a picture of a person." Now this is the type of image that would be produced by a person who has a lot of cell and tissue loss in their parietal lobes. And so what it basically exemplifies is that the person knows that a human is composed of appendages and facial features and a torso and head, but the person is unable to put them together in a sensible or realistic way. And the way that this is exhibited in terms of symptoms is that sometimes people with dementia will, for instance, not know the sequence of how to get dressed, right? So they may wake up in the morning, all their clothes are laid out on the bed, but they don't understand that your underwear goes on before your pants. Or maybe they'll put their socks on their hands, or they'll try to put their shirt on and get lost in the holes. That's an example of how changes in this part of your brain that manage spatial reasoning can result in symptoms that we see that can be difficult to manage. I also love this picture at the bottom. This is a typical clock draw. So one of the standard tests that clinicians use to measure a person's cognitive abilities or disabilities is the MMSE, which is a mini mental status exam. This little clock draw is often a part of these sort of basic mental status tests. And it's one of my favorite things to see because I think it tells you so much about what a person, how dementia is affecting an individual person. So sometimes we'll see clocks like this, which are, I mean, this is pretty good. The person knows that 12 is up top, and they have a basic idea of the fact that the numbers go around the circle. So, I mean, in my opinion, that's not too bad, although you've got this whole left side neglect. Sometimes you'll see clocks where there's a 12 over here and a 1 out over to the side, and then it all kind of goes by the wayside. But it's an example of the fact that the person is aware that a clock is round, that numbers are involved, but they no longer have the ability to sequence that correctly and to create an image that actually represents a clock. Other examples of damage to the parietal lobe and how it results in symptoms. I have, in my career, experienced residents who become very confused by carpeting with, like, you know, spots and stuff on it, colorful or complicated carpeting, because they're unable to realize that the spot on the floor isn't something that needs to be picked up, right, or vacuumed up. Or maybe they're looking, I had a great resident who I loved so much who really believed that the person in the TV was right there. And there was nothing that you could do to convince this person otherwise. Touching the screen didn't work. It was just impossible for her brain to make sense of the fact that the person that she was seeing was not with her physically. Let's see if I'm missing anything good. Oh, yeah, of course. This is also the reason why people with dementia become lost in familiar environments. First, we'll get in a moment to memory the fact that something that's familiar now may no longer be familiar to a person once they begin to lose cells in their hippocampi, and therefore are unable to store memories. But also just navigating familiar environments becomes more difficult as dementia progresses. Oh, this is another good one, guys. Okay. The temporal lobes. So the temporal lobes, as you would imagine, are where your temples are. They're sort of right here above your ears on both sides of your head. So obviously you have a left temporal lobe and a right temporal lobe, and these are responsible for language and recognition. Interestingly, the left temporal lobe and the right temporal lobe have distinct functions. All right, so the left side, and just so you know, we're looking at an image here that is reversed. So basically, this head is like this. The eyes are up here. This is the top of the head that we're looking at, and the feet would be way back that way. So this is the left-hand side, and you can see this black space means lack of tissue. So you can think of that as air. And what we see in Alzheimer's dementia is that the left temporal lobe is affected much more significantly than the right temporal lobe. And this image shows that very well. You can see here this white squiggly stuff in the same area as this blank space. That's brain tissue that's preserved, right? So this is a person with dementia. They have certainly lost some volume in their right temporal lobe, but they've preserved a good amount. And their left side is really quite significantly affected. So of course, as things go, the left side is, the stuff you'd really like to keep. So what's lost in Alzheimer's is formal language skills. So this is the ability to receive complex information through conversation or through reading, and also to transmit the same thing. This becomes impaired in dementia, the ability to read a book or follow a storyline as an example. Also, and I think in many ways most hallmark of Alzheimer's is recognition of familiar faces and places. This is often retained in the early stages of Alzheimer's, but towards, in the middle and certainly in the end stage of Alzheimer's disease, I think one of the saddest and most difficult aspects of this disease process for loved ones is that people with this disease become unable to recognize things that are familiar to them, including people that they loved very much in places like home. Alternatively, the right hand temporal lobe is relatively preserved, and that's where that is the part of the brain that allows you to appreciate music, allows you to conduct social chit-chat, that allows you to pull up dirty words or sexual talk or behaviors. The sort of thing you wouldn't desperately want to hang on to. But that's what you're left with. So, rhythm and music, it's wonderful. There is a lot of research and, obviously innumerable anecdotes of people with dementia who are able to appreciate music and the arts far into their disease process. If you're a person who uses the computer, get online and type, dementia and music into Google and pull up the first video, and you'll see some heartwarming example of a person with severe dementia who maybe doesn't really speak much anymore, and who is completely reliant on caregivers for assistance, and then a song from their youth is turned on and they start to sing along, and it's like this miracle that music is able to provide. And this is the reason why, because this part of the temporal lobe is preserved. It also is the reason why, oftentimes people with dementia, and I think this is a blessing, oftentimes people with dementia are able to preserve the function of social chit-chat. So they may be able to sit with you in the bistro and say, "Hi, how are you doing? Isn't it a beautiful day? The chicken was kind of weird today." Basic, everyday conversation, but they wouldn't necessarily be able to follow along with you in a discussion about politics or what you saw on the news the day before, or something more serious, which would be controlled by the left temporal lobe. And I also think it's important. I think that this helps to explain why many times people who are suffering from dementia will use words and exhibit language and perhaps behaviors that they never would have before. So you have a loss of your big words and your good semantics, right? That function is lost. You have sort of a pool in your mind of all your dirty words and thoughts that you've suppressed, and your filter is no longer working very well. So, it's a recipe for what we call behaviors, but actually is, when you learn this, sort of a reasonable response to life, if this is the part of your brain that is functioning and there's a part of your brain that is not functioning. All right, the hippocampus. So you have two hippocampuses. I'm going to call them hippocampi because it's fun and it might be correct. And they are located inside your temple. If you sort of pushed in from your temple about 3/4 of an inch or so, which you would not want to do, you would run into your hippocampi, and these allow you to form and maintain memories. And as I mentioned earlier, memory is really the hallmark symptom, loss of memory is really the hallmark symptom of Alzheimer's disease. I think if you were to stop someone on the street and say, "What is Alzheimer's disease?" they would say, "It's when you lose your memory," right? I don't think that they would say, it's when your spatial reasoning and your cognition and your emotions become different. That's what people think, and it's certainly true. And as I also mentioned earlier, it's this, in many ways, the saddest thing about having this disease, because we live varied and rich lives. And when a person is affected by this, terrible disease, there comes a point when they're unable to relive or appreciate the memories that they made during the course of their life, and that is really devastating. So the hippocampi, this is a great picture as well. I love these comparative pictures. Here on the left is an example of a section of brain. This down here is the little hippocampus, and this is a nice normal or control brain. On the right, we see an image similar or at least comparable to the one that I showed you at the beginning of the presentation, which shows a slice of brain that is significantly lesser in terms of volume than the normal one, and this is a person who's affected with Alzheimer's, and you can see how significantly the hippocampus has changed in size. And this is visual evidence of the fact that this very specific part of the brain, which is designed to allow us to have and maintain memories, no longer is able to function in the way that it was before. With all of this tissue loss comes, millions of highways that are no longer functional. And so it's very important to understand that people with dementia cannot form new memories. They cannot. And I think that's very difficult to accept, but it is functionally and physically the case that they simply are not able to form new memories. No matter what you do, it can't be altered. This is, however, here's a good thing. So you can't form new memories, but for a good period of time you can remember the old ones, and particularly the oldest ones. And what we find is that people with dementia often time travel a bit. So their reality might not be the reality, or at least the context that you and I are experiencing today. Their reality may be a context that they experienced 30 or 40 years ago, particularly if that context involved emotional memories, which can persist for a very long time, throughout a person's experience with the disease process. So what I mean by that, an example of an emotional memory is, an olfactory memory, like the smell of your grandmother's home, or the pleasant memories associated with the smell of freshly baked cookies, right? Those sorts of memories can persist for a long, long time. So a person with, moderate to end stage dementia might, perk up and smile and come to life a bit in a room where pumpkin pie is being baked, because it brings to mind emotional memories that are positive. Likewise, negative emotional memories are certainly possible. So a person who has treated you badly in the past, if you have dementia and don't necessarily remember them, it certainly is possible that you might have a negative, that a person with dementia might have a negative feeling when around them because that emotional memory persists. I think that's good. Occipital lobe, we're almost done with the brain tour. I think this is awesome, but I try to go fast because I know it can get, other people might not love it with the same sort of fervor that I do. The occipital lobe is in the back of your head, and interestingly, because it's very far away from your actual eyeballs, this is the part of your brain that is responsible for visual processing. I think that frequently we forget about the effect of sensory deficits on people with dementia. So when you are losing brain tissue and it's becoming more difficult for you to do most things in your life, in addition, the occipital lobe is affected, and therefore your vision is affected. So the way that I like to teach nurses and CNAs is to take, I'm going to have to stand up again, to take their hand like a binocular. We all do it? Yes, thank you, participation. All right, so put it up to your eye, and close your other eye, and you can see this is basically the visual field of a person with, moderate to advanced dementia. What happens is that the eye itself has not necessarily changed. The cells in the eye might not be diseased, but the cells in the brain are. And so so the body basically says, the most important vision that I have is the vision that's right in front of me. The vision on the outside used to be really helpful, and it would sort of be nice to have, but I have to focus on the vision that's right in front of me. So the brain focuses all of its attention on being able to maintain this central visual field, and the peripheral vision becomes impacted, even if there's not something wrong with the eye itself. And I think this is a wonderful tip to know, and it's really critical to caregivers to know that someone with dementia, even if they have wonderful vision, approach them from the front. Be slow and purposeful if you're approaching them from the side, because you're likely to startle them. They're not likely to see you or to appreciate things in their environment that are on the periphery, which I think is interesting. And then if you combine that with the fact that a good majority of older adults have other visual and sensory impairments, it becomes even a more pertinent issue, right? So if you have macular degeneration, which causes loss of vision in your central vision, and you have dementia and your brain is trying to shunt all your visual abilities to the center, you've really lost a great deal of your visual field. Plus, so now maneuvering your environment is going to be difficult. Plus, you couple that with what I was saying several slides ago, changes in the part of your brain that is responsible for spatial reasoning and mapping. It's very easy to understand why someone can get lost in a new environment, or why someone would fall more frequently as a result of changes in the brain. All right. Oh gosh, I have one more, I'm sorry. The coronal midbrain. This one's also really neat, and I didn't know anything about this until I began to research dementia's effect on the brain. So we're going to talk about motor skills and sensory processing just really quickly. So think about two headbands going completely across the top of your head, so from ear to ear. One of them, the one in the front, is responsible for movement, and the one in the back is responsible for sensation. And this is a nice healthy brain that we're looking at. I gotta flip my little clicker around. Nice healthy brain up top, but down here you can see this is a brain of a person with Alzheimer's disease, and now everyone with Alzheimer's disease, the tissue loss is going to be inconsistent. Everyone is going to be a little bit different. Everyone's symptoms, therefore, are going to be a little bit different. But you can imagine now that areas of the brain responsible for movement and sensation, just like all the other areas of the brain, can be affected. So an example of how this might affect a person with dementia is that they are going to become more at risk for pressure ulcers. So when I go back and watch this video, which is torture, I will probably notice that I've been up here fidgeting most the whole time that we've been together. And, I'll find that a little bit horrifying. But really what it is my brain working correctly. The sensory part of my brain is able to receive signals from my environment. So as I'm sitting here, my brain recognizes that my sit bones have been squishing my skin and that I need to shift so that I don't get a pressure ulcer, right? So I have a sensation that the sit bone hurts. I shift my body and move so that I allow blood flow to that area and I keep nice, healthy, intact skin. A person with dementia, and of course people with lots of other diseases that affect these sorts of things, might not be able to achieve a neurological signal going from the sensation from their skin up to their brain to tell them to move, and therefore they have a lack of initiation of movement. And they may stay in one position for hours and hours and hours unless someone comes to move them. Another example of how this affects people with dementia is hypersensitivity. So you would think that as tissue dies in the part of your brain that regulates your sensation, that it would cause a lack of sensitivity. And in some cases it does, but consistently people with dementia experience hypersensitivity, particularly of regions that are more sensitive throughout the lifespan. So the lips, the fingertips, the genitals, the soles of the feet. And frequently these are parts of the body that caregivers have to be involved with in order to take care of someone, right? So we might help someone brush their teeth, or we might help someone wash their hands. And it's difficult to recognize, if you haven't had this sort of education, that because of brain loss, because of the pathology of the brain, as it's experiencing this disease process, a person might be incredibly sensitive in the mouth. So we go to brush their teeth like you or I would like it, you know, with a good amount of pressure, and it's so sensitive to the person with dementia that it hurts. And then they become fearful of having their teeth brushed. And maybe they'll exhibit a behavior when someone comes to them with a toothbrush, or they'll try to bite, or they'll use a swear word, because that's the word that's available. They're not able to say, gosh, my mouth is really sensitive, but they're able to say something real socially unacceptable. And, and I think, I just love talking about this, because I think that when you have all these pieces of the puzzle, it makes it so much easier to empathize with what our friends with dementia are going through. All right, disease progression. Usually I spend a lot of time talking about this. I'm not going to today. I'm just going to blow right by it, except to say that what's hallmark about Alzheimer's disease is that it is progressive. A person with Alzheimer's disease will experience a slow and relatively steady decline in their functional abilities until ultimately they die as a result of the disease, unless they die for another reason in the intervening time. But that does distinguish Alzheimer's disease from other dementias, such as vascular dementia, for instance. Oh, well, I'll go back a little bit, maybe. Yeah. The other thing that I wanted to say is that, you know, should you be interested in learning about the progression of Alzheimer's disease, it's certainly something that's worth looking up on the internet, but it can be a little bit confusing, because you know, different organizations and different individuals distinguish the stages or the progression of Alzheimer's disease differently. And so, you know, I used to give this presentation and go through a bunch of gems, like gemstones that correlated to different parts, and it got too confusing. I couldn't remember it. I gave the presentation like 10 times and I couldn't remember it, so I gave up on that. Another equally confusing set of stages is stage 1 to 7. A doctor, Dr. Reisberg, has introduced the 7 stages of dementia. And to me, they're just a little bit, they're accurate when I look at them and look at them through the lens of my experience, but they're a little bit convoluted, right? You have like early or mild, mild to moderate, moderately mild, and it's too much, I think, to help make a very complicated disease process more understandable to the layperson. So for me, when I think about dementia, I think about mild, which could also be early. So early to mild, this is the green happy head, although it's starting to age. But, and then, so early to mild, you know, moderate, and then end or severe. And certainly, it may be worth looking at those symptoms, or come talk to me about it sometime if you're ever curious about the disease progression. All right, so we're going to move on from Alzheimer's, and we're going to quickly run through a couple of other dementias, and then Stephen and I will be hanging out up here, and we can take your questions or talk to you about anything you want to talk about on this topic. But vascular dementia, I think, is most likely much more common than it is diagnosed. Vascular dementia is caused by damage to blood supply in your brain. I think about it essentially as the result of microscopic blood clots cutting off areas of the brain, right? So these would be, a TIA can be an example, but basically these are little tiny microvascular blood clots that disallow small portions of the brain from functioning. So what distinguishes this from Alzheimer's disease is that one portion of the brain generally is going to be affected with each little event, right? So instead of having a global loss of brain function that sort of slowly and steadily progresses, you have little spurts of changes. So you may have a little clot that affects your parietal lobe, and as a result you have some trouble getting lost in familiar environments, right? Or you may have, oftentimes the frontal lobe, interestingly, is more likely to be preserved. So you're less likely to have these filter personality impulse control deficits that a person with another type of dementia might have. But it's stepwise. So you have this one event that affects a part of your brain, you have a deficit, and you stay pretty much at this functional ability for a long time. And then, 2 weeks or 2 years later, you have another event and it affects another part of your brain, and then you now have an additional deficit and you stay at this space for a relatively long time, right? And so that's the difference between vascular dementia and Alzheimer's dementia, and it's not uncommon at all for these two to be mixed, for a person with Alzheimer's disease to also have a vascular component. One thing that's great about vascular dementia is that, to a certain extent you can prevent and treat it by doing things that would prevent stroke and heart attack. I think another good point is that people with vascular dementia do tend to be more aware of their own deficits. So a person with early Alzheimer's disease is sometimes, but not always, aware of the changes in their memory or changes in their functional ability. But usually a person with vascular dementia is very attuned to the fact that there's been a change, particularly in the beginning of that disease process. They're generally very aware of these sort of sudden changes in their ability. Lewy body dementia is related to Parkinson's disease. Lewy body, so I showed you how those tangles and plaques affected the brain of a person with Alzheimer's disease. In Lewy body, there are actual little bodies. These orange guys are not supposed to be there. So these are the Lewy bodies that actually are found within the cells of people with this disease process. It's the second most common form of dementia, and the hallmark of Lewy body disease, at least in my practice, is hallucinations. And I find, I think I may have said this last time, so they tend to be visual hallucinations, although I also see a lot of auditory hallucinations in people with Lewy body disease. Auditory hallucinations are usually music playing that's actually not playing. People with this disease will hear operas or piano concerts that actually aren't going on, which sounds kind of lovely, right? But I also find that the most common visual hallucination in people with Lewy body dementia is children, seeing children, or at least human images. There is a fluctuation in alertness and attention, and these people also tend to show symptoms that are related to Parkinson's disease, so tremors, rigidity, masked face, and other symptoms. Frontotemporal dementia. I've seen frontotemporal dementia in older adults, certainly, but this is also a disease that can affect people who are younger, and it causes, rather than a more global change in brain structure, it causes symptoms that affect primarily the frontal lobe and the temporal lobes. And so what you see oftentimes is a rapid and significant change in personality, a lack of impulse control, a lack of safety awareness, an increase in or onset of socially inappropriate behavior, sexually inappropriate behavior, and difficulties with language, transmitting and receiving language. And this can be a truly devastating type of dementia to have because it so rapidly and significantly affects aspects of a person's ability to function in a social environment. All right, and we'll fly through this. I have 3 more slides just to share a little bit of information with you about recommendations for how to interact with a person with dementia. So I'll just go through them, rather quickly. So obviously, when you're interacting with a person, with anyone, you should probably approach them with some positivity, right? But if it's a person who's struggling with a lot of things because their brain is no longer working the way that it used to, then doing, these few simple things to help make your interaction more gentle can result in an experience that is more pleasant for you and also for the person with the dementia. So you want to greet the person slowly and from the front, right? And let them know who you are. Hi, my name is Taryn, I'm a nurse, I'm going to be taking care of you today, with a smile. If the person's in a wheelchair, I might kneel down and get on their level so that I'm not threatening. Even if it were my mother, I wouldn't walk in and say, who am I? Right? Because that's stressful. That's a lot to take when you really don't know where you are and you might not know who someone is. Instead, I would come in and say, it's Taryn, I'm your daughter, I'm here to see you today. Smile and take her hand, right? Move slowly. I think this is all, that's good, I hit that, okay. Communication, so this is communication when you just want to have a friendly interaction. It's important to remember that the language centers have been affected, so you want to speak slowly and clearly. You don't want to overwhelm the person with information or choices. So for instance, if you're trying to help someone with dementia get breakfast, it might not be the most helpful thing to say, what do you want for breakfast? You might want to say, would you like cereal or would you like toast? That's a lot easier to manage when many parts of the world are confusing and overwhelming. You want to acknowledge the person's emotions. It's okay if they're feeling angry or frightened or happy, and you want to go with it. You want to be prepared to repeat yourself because the person cannot remember what you said, and sometimes they can't moment to moment. One of my favorite residents ever, her memory reset about every 3 or 4 seconds. It was just rapid fire. I used to change a dressing on her leg. I changed it every day, and it would take me about 30 minutes, and it was the same conversation at least 30 times throughout that. Who are you? Well, I'm Taryn, I'm your nurse, I'm changing a bandage on your leg. Who are you? I'm Taryn, I'm your nurse. And it's important to try to not let that frustrate you, to instead be empathetic to the situation, to know that the person is unable to remember what you told them just a minute ago, and to remain pleasant and positive and calm and understanding. And I'll tell you, I'm proud because I feel like every single time I said, I'm Taryn, I'm my nurse, I'm your nurse, I tried to say it like it was the first time, right? Like every single time I wanted her to know that I was friendly, I was safe, I was there for her, she was going to be okay. And it's really important to know that you need to be consistent with that approach. And don't argue. Go with the flow. It's like a mantra for marriage, right? But it works for the demented too. Really, it's important to meet people with dementia where they are. They might be 50 years in the past, and that is okay. In fact, there are so many things that are hard about this disease. I say travel 50 years back with them and have some fun for a while, right? Don't try to force a person with dementia to live in your reality. It's going to be upsetting to them, it's going to be confusing, and it's going to harm your relationship because it can cause that person then to develop negative emotional memories as a result of your interaction. Instead, figure out what's going on in their mind right then, and my goal is, where are you? How can I be what you need right now, wherever you are? I had another great example. I worked in a locked dementia care facility when I was first a nurse before I came to Deerfield. And I had 24 residents with different stages of dementia, and it was just me and 2 CNAs every night from 3 to 11, and it was wonderful. It was the best. I don't remember what story I was going to tell you, but it was probably a good one. Oh, I remember. Okay. See, that is normal aging. Okay. But I was with a resident one night, and there was a thunderstorm, and she was probably in her mid-90s, really significantly demented, blind, and she was crying in the corner, and no one could get her to leave. They were saying things like, it's dinner time, come here. Well, I spent a little bit of time talking with her, and one of my favorite things to ask people with dementia, and this is probably not the best professional advice, it's just personal advice, is I'll say, how old are you? Because it helps me understand where they are. And in this moment, I said, Anne, how old are you? And she said, I just turned 10. And I said, oh, really? Did you have a birthday party? She said, yes. My mom and dad took me to the park. And I said, oh, that's great. And she said, I can't find my mom and dad now, and I'm afraid of the thunder. And then I knew exactly what she needed, right? And so instead of being a nurse, I tried to be a mom, right? I tried to be what she needed me to be then. And you can do that too with the people that you love with dementia. You can find out right where they are and try to be what they need. When you're trying to get someone to do something, I think I've been through this, break it down, make it easy. It's not going to be, let's say I'm a person with dementia and you want me to get up out of this chair. This is a frequent problem. It's not going to help to come up and say, Taryn, get up. Right? I might not understand what get up means. I might not any longer remember the steps and the sequence of getting up. I might not be able to hear you very well. Maybe you came at me from the side. I can't see you. So the best thing to do in that sort of circumstance is to break down the steps as much as you possibly can. So I might say, okay, put both of your feet flat on the floor. Now lean forward. Put your hand on the chair. All right, now I want you to use your arm muscles and push up, and I'm going to help you stand, right? These are the sorts of things that you need to do to communicate with a person who is no longer able to sequence basic things for themselves, and it will really help you to achieve minor tasks. Also, asking people to help is a really wonderful tip. Even when we have significant dementia and we're old and we're in pain and we're tired, if you say, would you help me with something, it works wonders. So you might go up to Taryn with dementia and say, I really need your help. Would you let me help you stand up so you can come over here with me, right? And it is a motivating factor, I find. And yeah, I think we've already been through this. I think the last thing is that dementia is really hard. Sometimes people with dementia are going to have behaviors that are difficult to deal with because we're not used to interacting with people in this way. Sometimes people with dementia are going to be sad, or they're going to have outbursts, or they're going to be physically aggressive, or they're going to yell or spit or whatever. And this is a result of a person who has a need, who has something to say, and who is unable to say it. And so my recommendation is to do your very best to maintain your calm and friendly approach. And don't be afraid to back off, to give up. You don't need to brush your hair right now. Fine. If this is not the moment, then I'm going to go do something else, and I'll come back and try again later. Maybe I'll try in a different way. This is something that I think is really, really important to impress, particularly upon nursing staff, and it's one of the things we teach our CNAs, that if someone's having a bad moment, then you don't need to do it right then. Very few things need to be done right this second. Most things can be reapproached later. And this is Stephen, do you know who gave this to me?
Elizabeth Byerly.
Elizabeth Byerly. I love this. I've never forgotten it. It is the Chinese symbol for active listening, which I think is really nice that they have a different symbol for listening than active listening. And you can see the words yourself, but different parts of this symbol are composed of symbols that mean different things. So ear, eyes, undivided attention, and heart. And I will leave you with that. And Stephen and I will be here to talk to you.
Thank you so much, Taryn. What a bunch of really fantastic